Welcome to The Explainer. Today, we're diving straight into the intense, split-second decision-making of advanced trauma and vascular surgery. We're going to look closely at the clinical management required when human lives are literally on the line, using some specific clinical vignettes to uncover the actual surgical rules of engagement.
Here's our surgical briefing for this explainer. We'll track the patient journey from the golden hour of the trauma bay down to definitive reconstructive care in the OR. We're moving sequentially through thoracic trauma and resuscitation, then peripheral vascular injury management, and finally, lower extremity surgical amputation.
All right, let's jump right into Section 1, thoracic trauma and resuscitation, focusing on the ABCs of trauma, specifically airway and breathing.
Put yourself in the shoes of the trauma attending with this clinical vignette. You've got a 22-year-old male brought in following a high-impact motor vehicle deceleration crash. He's in severe respiratory distress, has extensive palpable subcutaneous crepitus, and a massive right-sided pneumothorax. But here's the really alarming part. There is a persistent, continuous bubbling air leak through his chest drain. So what injury should be suspected here? Think about the underlying pathology causing that continuous air leak for a second.
If you guessed a major tracheobronchial tree injury, like a tear of the mainstem bronchus, you hit the nail on the head. The absolutely crucial point here is that an urgent fiber optic bronchoscopy is mandatory to localize the exact site and extent of that tear. While small linear tears might just be observed, extensive injuries require primary, single-layer repair using absorbable monofilament sutures, with the knots tied strictly outside the tracheal lumen. And here's a really fascinating surgical exam pearl for you. To minimize tension across that fresh tracheal repair post-op, the patient's neck is actually kept fixed in a flexed position. They do this by suturing the chin down to the anterior chest wall for the first 10 to 14 days. Pretty wild, right?
Moving on to resuscitative access. Now, we know an iatrogenic pneumothorax is a recognized risk of central venous access procedures. But of all the standard central venous access routes, which one carries the highest statistical risk of being complicated by an acute iatrogenic pneumothorax?
It's the infraclavicular subclavian vein catheterization. And the reason comes down to the risk profile. The subclavian approach carries a 1 to 3% risk, which is significantly higher than the internal jugular. Why? Well, because the needle track passes dangerously close to the very top of the lung cavity, known as the pleural cupola. This actually brings us to a massive golden rule in trauma. If you fail a subclavian line attempt on one side, you must never immediately jump to the opposite side without clearing the chest with an X-ray first. If you accidentally cause bilateral pneumothoraces, it can literally be fatal on the spot.
Let's escalate things to the ultimate emergency room scenario, where seconds determine survival. An unstable trauma patient comes in with a penetrating thoracic wound and enters cardiac arrest right there in the ED. The team has to open the chest immediately. What is the most versatile and commonly utilized surgical approach for an emergency resuscitative thoracotomy? The answer is the left anterolateral thoracotomy, executed right through the fifth intercostal space. This approach is brilliant because it gives surgeons rapid, completely unobstructed access to the left lung hilum, the pericardium for cardiac massage, and crucially, it allows direct cross-clamping of the descending thoracic aorta to preserve blood flow to the brain and heart. By comparison, the right anterolateral approach is really only indicated if you're specifically targeting right lung structures or the superior vena cava.
Okay, we're moving down the body now to Section 2. Peripheral vascular injury management, shifting our focus to hemorrhage control and catastrophic bleeding in the limbs.
Let's look at a penetrating trauma vignette to uncover some surgical rules of engagement. A 28-year-old patient presents with a gunshot wound to the thigh, and the track places the superficial femoral artery directly within the zone of injury. Which clinical finding constitutes a definitive, hard sign of vascular trauma that warrants immediate operative exploration?
If you thought about the complete absence of palpable distal pulses, you are absolutely correct. These hard signs are golden rules in surgery. If a patient exhibits absent distal pulses, active pulsatile hemorrhage, and expanding hematoma, a thrill or bruit, or an ischemic limb that's pale, cold, and paralyzed, that mandates immediate transfer to the operating theater. You completely bypass the delay of diagnostic imaging like a CT angiogram. No waiting around. And remember, bedside blind probing is strictly contraindicated here because it carries an extreme risk of provoking uncontrollable hemorrhage.
This brings us to a really fascinating juncture. How does severe patient instability change the textbook rules?
Imagine a 44-year-old polytrauma patient with an open femur fracture and a completely mangled right leg. In the OR, both the popliteal artery and popliteal vein are found transected. The absolutely critical detail here is that he's hemodynamically unstable, with a blood pressure of 85/60 despite active resuscitation. So how do you manage that popliteal vein injury in this state?
In this scenario, the answer is direct ligation of the popliteal vein. This is a perfect example of why an unstable patient gets a vein ligated via damage control to literally save their life, while a stable patient gets it repaired. Complex vascular reconstructions take a lot of time. When a patient is in profound shock, the surgical priority immediately shifts to rapid hemorrhage control. You just tie off the vein. Yes, ligation carries a high risk of chronic, long-term lower limb swelling, but it keeps the patient alive. Now, if the patient were stable, the axiom dictates repairing or grafting that vein to prevent severe post-thrombotic limb edema.
Now, assuming the patient actually is stable, how do we piece a mangled limb back together? Let's say a 24-year-old male with a thigh gunshot wound has a 5-centimeter structural defect in the superficial femoral artery. That's a gap way too large to pull together under tension. Plus, he has a comminuted femur fracture. What's the absolute gold standard reconstruction sequence here?
While there's a rigid 3-part sequence, surgeons must strictly follow when facing combined orthopedic and vascular trauma. First, you place a temporary intravascular shunt to get blood flowing to the leg immediately. Second, the orthopedic team applies rigid external bone fixation so the leg is structurally sound. And finally, you perform definitive reconstruction using an autologous reversed saphenous vein graft. You actually have to flip or reverse that vein graft so the internal venous valves don't end up blocking the forward arterial blood flow.
But what happens if that native saphenous vein just isn't available? While autologous vein grafts are the gold standard for sure, off-the-shelf synthetic conduits like EPTFE or woven Dacron can totally save the day when veins are stripped or destroyed. However, they definitely come with trade-offs. Synthetic grafts carry a significantly higher long-term risk of thrombosis and intimal hyperplasia, which is essentially a thickening of the vessel walls. Even more critically, they carry an extreme risk of infection and catastrophic breakdown if you place them into heavily contaminated open wound beds.
All right, let's move into our final section, slowing the pace down from the chaotic trauma bay to the elective operating room. This is Section 3, Lower Extremity Surgical Amputation, where we'll explore the meticulous science and geometry of definitive reconstructive care.
Let's start at the most distal point. A 53-year-old diabetic male presents with advanced gangrene strictly confined to his right great toe. Here's a high-yield clinical pearl for you. Using the highly reliable probe-to-bone test, where a sterile probe hitting a hard, gritty bone surface indicates an 85% probability of infection, we confirm frank osteomyelitis. Given that, what's the most appropriate surgical management? The treatment of choice here is a surgical ray amputation of the right great toe. This involves excising the toe along with the distal portion of its corresponding metatarsal head. The crucial reasoning here all comes down to biomechanics. You see, the great toe dictates the foot's windlass mechanism. It's this incredible biological pulley system that protects the foot during the propulsion phase of walking. Because of that, preserving as much of that metatarsal shaft length as possible is vital to maintaining the patient's baseline midfoot stability and balance.
Now, as we move up the leg for more extensive disease, like wet gangrene encompassing the entire foot, a transtibial or below-knee amputation is required. This is where surgical geometry becomes paramount for future prosthetic fitting. To ensure adequate coverage of the bone stump using a Burgess technique, what is the recommended length of the vertical posterior myocutaneous flap relative to the anterior transverse skin incision?
The posterior flap must be exactly 1.5 times the length of the anterior transverse cut. So why is this ratio so incredibly specific? Because this exact layout ensures the flap can wrap anteriorly to cover the exposed tibia completely without any tension. If those skin cuts aren't calibrated properly, it leads to redundant structural skin folds. Clinically, we call these dog ears, and they severely complicate fitting a prosthetic socket later on.
And speaking of prosthetics, whenever surgically possible, like utilizing a skew flap design to place incision lines away from the sharp bony edge of the tibia, surgeons will fight tooth and nail to preserve the native knee joint. Why? Well, preserving the native knee joint via a below-knee amputation lowers the metabolic energy expenditure required for long-term walking by a staggering 50% compared to an above-knee amputation. That is a massive difference for the patient's quality of life.
Synthesizing all of this, we can see how each level of amputation, from the ray amputation of a single digit all the way to a transfemoral above-knee amputation, balances the absolute necessity of excising dead infected tissue with the biomechanical reality of long-term prosthetic rehabilitation. An above-knee amputation, for instance, demands really high metabolic energy and requires myotasis. That's suturing the severed muscles directly to the bone just to maintain adductor power.
As we wrap up this explainer, consider this provocative reality. A surgeon's split-second decisions on the operating table fundamentally alter a patient's lifelong biomechanical energy and mobility. Think about it. From clamping a descending aorta in the trauma bay to perfectly measuring a 1.5 ratio flap on a calf, how incredible is it that the exact placement of a surgical incision today completely redefines how a human body is going to move for the rest of its life? Thanks for joining me today, and keep questioning the mechanics behind the medicine.